we there yet?
Definitely we are. Thank you so much for the invitation, and thank you for the committee here. Appreciate that. These are my disclosures. And just to talk about the background, what does radiation segmentectomy mean? So there's several ways of doing Y90. You can do Y90 by injecting Y90 in a bilobar fashion. You can do a unilobar. You can also do a segment, and you can also inject it directly into the tumor with a little margin around it. And when we inject it at a very high ablative dose, that's what we call radiation segmentectomy. So we go very distal with our microcatheter, as you can see in this picture here, very close to the tumor, but not just a tumor. We always include an area around it. And then here's the tumor, here's the angiogram with the microcatheter in position, and then you inject a high ablative dose, like really high dose. It's not the one that is recommended by the vendor, but it's really high, and we'll talk about the dose in a second. And this is what you get eventually, is that there's this whole area, which is the segment that you treated, is completely ablated. Everything dies, the tumor and the surrounding, I wouldn't say normal liver, but the cirrhotic liver around it that doesn't have also tumor. So this is the first study that was done by Riaz, or was described by Riaz as a radiation segmentectomy. That was in 2011, so almost like 12 years ago. As you can see, they used the uniform distribution dose of around 500 grays, which is much more than what is recommended by the vendor, which is around 120. So they're using really 3 or 4 times the dose that is recommended by the Y90 vendors. And as you can see, you know, the median survival of these patients was pretty high. There was no side effects. There's only 5% of small biliomas that were treated conservatively, and 1% of the patients only had biliary strictures. There was no RILD, which is radiation-induced or radioembolization-induced liver disease. This is another case that I did in our institution. You can see there is a small tumor here in segment 7, which is again typical for or have imaging features that are typical for HCC. And this is the delayed washout, and we did an angiogram here, and you can see here's the lesion. We went with the microcatheter very close to the tumor, and on the day of treatment we usually do cone beam CT, which is CT that is done in the angio suite itself to verify that the location is accurate and correct. And you can see here's the tumor, and here's the segment that is going to be wiped off, completely dead after the injection of the high dose. And here is on the day of the treatment. We even went further into the vessels here, very close to the tumor. So this is the whole area that will be wiped off. Again, this is the SPECT CT that is done after the administration of the Y90. You can see that on the follow-up after 1 month. This is the area that had the tumor. It's completely gone. It's completely necrotic. This is the coronal image showing the same thing. This is after 3 months. The area starts to shrink. That's what we call segmentectomy. That segment is going to disappear after some time. Here is after 6 months, more shrinkage, and then it completely disappears and becomes fibrotic. So, and then Vouch in 2014 wanted to correlate this ablative therapy. He wanted to study whether this is really an ablative technique or not by correlating the radiologic follow-up with pathologic correlation. So he looked at 102 patients who had solitary HCC less than 5 centimeters, and they did radiation segmentectomy with the same technique that was described by Riaz, and the median dose that was given was 240 grays. 33 patients in that study had liver transplantation. This is how they got their pathologic correlation. So they found out that there is 90 to 100% tumor necrosis in all these patients, and the median median time to progression was 33 months. The median overall survival was 53 months. Very, very close to what we get with ablation and also with probably resection. So they also found, or they did some dissection into the patients and found that those patients who had a dose of more than 190 grays actually had almost complete pathologic necrosis compared to when you give a dose of less than 190, and that was statistically significant. So in other words, they were trying to advocate for giving patients more than 190 at least. So this is, of course, is more than what the recommendation of the vendor is, which is 120. Indications and contraindications as it is right now, of course, it's still a new technique relatively compared to the other curative treatments in the BCLC guidelines. So it is done whenever the patient is not a good surgical candidate, or if percutaneous thermal ablation is not indicated, usually when there is a difficult location, and also, of course, if the patient fails the evaluation for liver transplant. So basically, if the patient is within the Milan criteria, he is eligible for the curative modalities. If these curative modalities are either contraindicated or not feasible, this is when we do radiation segmentectomy. Technique is very simple, just like I described it. We usually do cone beam CT at a lobar level to be able to see where the artery is, and then we do it at a target level, like very selective within the segmental vessels. We always look for watershed areas, because once you go very selective, that tumor might be getting supply from 2 arteries, and you can miss one of them. So instead of giving an advantage to the patient by giving him complete pathologic necrosis, you actually left part of the tumor, and that's why we have to do cone beam CT. An example of this is this patient here who has a tumor that is between segment 1 and segment 6, and this is a common watershed area. This is the angiogram from segment 1, the caudate lobe, and you can see the cone beam CT shows that this artery supplies the tumor. Here is the segment 6 artery, and you can see that this is also supplying the tumor, and here's the cone beam CT showing that. And so this patient was treated by giving Y90 at a high dose in both arteries, which resulted in complete necrosis, as you can see here, and after some time, of course, it disappears. This is another example of watershed lesion in segment 8, or between segment 8 and segment 4A, which is a common location for watershed lesions. Again, enhancing on arterial phase and washing out on venous phase, so typical of HCC. When we did the cone beam CT injection from the segment 8 artery, you can see that this is supplying the tumor, and then when we did it from 4A segmental artery, it's also supplying the tumor. So we gave a dose to both arteries, and it resulted in complete necrosis of that area. That's after 1 month. After 51 months, the patient was still alive. You can see it almost disappeared. So cone beam CT is also very, very important in order to accurately calculate the dosimetry by getting accurate volumes of this segment, so that you can accurately calculate the dose that you're going to give to the patient. This is an example of a tumor, again, in segment 8. Here is a very selective catheterization. You can see the tumor is right here. And this is the cone beam CT showing the tumor and the surrounding area that all going to die after giving the high dose, ablative dose of Y90. This is the coronal image. And you can see this is how you calculate the volumes of these areas, by drawing a region of interest around the area that is perfused, and that will get the Y90. Again, very fancy images, not really necessary, but very good to show you what area of the liver is going to eventually, go into complete pathologic necrosis. This is after giving the Y90. You see it's like very targeted to the area that had the tumor. We usually use the MERD model for this. There is different models for dosimetry. We usually use the MERD one because we're just basically aiming at wiping off this whole area. The MERD model relies on the fact that this will be evenly distributed. Usually it is not. So most of the Y90 will go into the tumor. Some of it will go to the surrounding liver or non-target liver. But again, this model actually is the best if you're going to do Y90 segmentectomy. So also I would say the success of doing radiation segmentectomy relies on giving a high dose to the area that you're going to treat, but also to minimize the dose of any Y90 that might go to other areas of the liver. So sometimes we have to use something like gel foam or flow modifying microcatheters in order to divert the flow into the segment that we need to treat, rather than the other segments of the liver that is usually just cirrhotic but doesn't have any tumor. This is an example of another lesion, and I apologize for the images. There is a lot of motion artifact here, but this is the tumor in segment 2/3. This is the delayed showing washout. And here is the angiogram. Celiac angiogram shows the tumor right here. It's it's hypervascular. And this is the left hepatic artery, and you can see it's probably supplied by this artery. So we went in there and did a selective angiogram, and you can see here is the tumor, but it also supplies all that part of the liver. So a major, a huge volume. And here is the cone beam CT. You can see it's supplying actually part of the tumor. That part is not supplied, and there's a huge part of the liver here that will be dead basically if you give a high ablative dose. Here is the other artery, which is segment 3 artery. It's also giving part of the tumor. So again, an example of how cone beam CT is very important to show you what arteries are actually supplying, so you don't miss one of them and then you disadvantage the patient by leaving some residual tumor. So this is the other half of the tumor, which is right here, that is supplied by segment 3. So it's getting from segment 2 and segment 3, and you can fuse both of them together to make sure that you are actually covering the whole tumor, as you can see in this image. And so this is the, again, the SPECT CT after the MAA administration, and you can see that probably we're gonna kill all this big part of the liver. So on the day of delivery, we went further into the artery and injected gel foam to block all this part, all these arteries here. Gel foam is a temporary embolic agent. It's going to recanalize again, so that part of the liver is not going to die. It's going to just, these arteries will recanalize and it will remain perfused. And then after we did this, as you can see, the arteries here are blocked. We pulled the catheter back and we injected the Y90 into that tumor. And then we went into segment 3 artery, which is the other artery. Again, went far in, injected gel foam here. As you can see, it blocked this area of the liver. And then we pulled the catheter back and injected the Y90, again, high dose, into the tumor, as you can see here, into this artery that went directly into that part of the tumor. As you can see here, it's now focal distribution of that, and you can see here the difference between without, or that's the one that we did before we injected the gel foam. You can see it's extending way into the liver here, but after you do the gel foam embolization, most of the Y90 goes into the tumor only. And here is the follow-up after 3 months. You can see that here, this is the tumor, and part of the liver here is also destroyed, but that part of the liver is still alive, and you can see it here also on the portovenous phase. This is after 6 months, complete necrosis of the lesion, as you can see over here. The rest of the liver here is still alive or perfused. Outcomes. This is a very important study, the legacy study, which was just released in 2021. There's another study, but I don't think time will be enough for us to go through all the studies. But we have a large body of evidence now supporting radiation segmentectomy. This was a retrospective study in 3 independent US sites that have a highly reproducible results. And what they did is they studied 162 patients with unresectable solitary lesion, less than 8 centimeter. So that's a huge lesion, or huge inclusion criteria. So these were BCLC A and C, no portal vein thrombosis, of course, and no extrahepatic disease. They looked at the objective response rate and duration of response. Duration of response, as you guys know, is the the length of time between having a response on the follow-up till the patient has a progression of his disease. So they used, of course, the modified or the mRECIST for the follow-up. Radioembolization was used as a primary treatment in 72% of the patient, as a neoadjuvant therapy in 27% of the patients. Neoadjuvant means it was used just for downstaging or bridging to transplant or to resection. Patients received selective infusions. Again, it's a radiation segmentectomy. You have to go very further with your microcatheter into the segmental arteries. So segmental infusions were used in 95% of the patients. The mean absorbed dose, again, was 410. Very high dose, not what is recommended by the vendors. So the objective response rate in these patients was 88%. Complete response and partial response. Complete response was seen in 84% of the patients. 4% of the patients had partial response. And as you can see, there was 0 patients who had progressive disease or stable disease. Everybody either had complete response or less likely partial response. This is the distribution again. You can see the green is the complete response. All the patients had either complete, few of them had partial response. Now, going back to this important table, duration of response was 15 months. And when they looked at the duration of response at 6 months, of more than 6 months, 76% of these patients had that, which is again like great results. Now, when you look at the percent of patients without tumor progression at 24 months, after 2 years, it's 100% in the liver. Nobody had recurrence again in that liver after 24 months. When you look at time to progression, and the median survival, it's 57 months, which is very comparable to ablation and even resection. So 3-year overall survival was 83, if you use it as a primary treatment, was 83%. At 36 months, was 86% for all patients at, again, 3 years. Great results, of course, very comparative, again, to the curative modalities, with the exception of transplantation, of course. Grade 3, now, is it associated with side effects? Grade 3 side effects occurred in 19% of the cases. The serious adverse events occurred only in 9.9%. 5.6% of those were related to the radioembolization. So really what's related to radioembolization is like 5% only. Now, none of these patients, there were some deaths, of course, but none of them were related to the treatment again. None of the patients had radiation or radioembolization-induced liver disease. In conclusion, or the study concluded that, the use of this technique, which is radiation segmentectomy, results in a meaningful response rates and prolonged duration of response, especially for solitary HCCs that are less than 8 centimeters in diameter. Overall survival and the PFS also compared favorably with curative therapies. Later on, Gubber in Northwestern also, he got the same patients. He looked at the pathologic correlation, just like Vouch did for the Riaz patients. So they found that if you use a dose of more than 400, all the patients will have complete pathologic necrosis. If you use a dose less than 400, so some of them will have partial pathologic necrosis. So I haven't really seen, studies that have gone so far from, treatment to radiologic comparison and then pathologic comparison as well, because some of these patients, also 45 patients, had liver transplant, so they were able to get pathologic results also. So again, very true study, shows the effectiveness of this treatment. This is another retrospective study done in Mount Sinai by Biderman. It compared basically the standard microwave ablation that we use mostly in the US. I know here sometimes they use radiofrequency, which is pretty similar, but this even compared TACE followed by microwave ablation, which we know has a higher efficacy compared to microwave ablation only. They compared that with radiation segmentectomy for solitary HCC lesions that are less than 3 centimeters in diameter. They included 80 patients in the TACE microwave group versus 40 patients. And then they also did propensity score matching, so we matched the patients because it's a retrospective study. So they matched the patients 40 against 40. And the results showed that if you don't match them, they're actually the same because the p-value is not significant. So it was 85 versus 88%. If you match them, which is the PSM, propensity score matching, these patients are again exactly the same, 85%. So radiation segmentectomy gives you exactly the same results as microwave ablation based on this study. Again, this includes both the progression-free survival as well as the overall survival. And again, p-values are not significantly different whether you do it without or with propensity score matching for these patients. Overall survival was also similar. P-value is not statistically significant. So this study concluded that imaging response and progression outcomes of patients with solitary HCC less than 3 centimeters in diameter that are treated with radiation segmentectomy are not significantly different from those treated with TACE and microwave ablation. This is another study, again, showing the efficacy, but I'm going to skip it for the interest of time. This prompted the BCLC algorithm to change, actually, and you can see now for this curative segment, which includes patients who are stage 0 or stage A on the BCLC algorithm, which usually get this curative treatments, whether ablation, resection, or transplant. These are the curative, or the patients that receive curative treatments. Now, if this is not feasible, or if it failed, you can do Y90 if the patient has a single lesion up to 8 centimeters in diameter. So in conclusion, radiation segmentectomy is a well-tolerated intraarterial therapy for HCC that is less than or equal to 8 centimeters in diameter. It could be used as a definitive therapy or as a new adjuvant therapy for bridging or for downstaging for transplantation or resection. Radiation segmentectomy has comparative outcomes to other curative treatments such as resection, transplant, or ablation, you have to use a tumor absorbed dose of more than 400 grays, to guarantee that you will have complete pathologic necrosis. And with that, I'm going to end. So thank you so much again. And just remember that tumor dose matters with Y90. The use of the standard dose is not going to give you what these results are. So it really matters a lot. Thank you.
Thank you so much for your presentation. Really very impressive and very good results. But I have just one question concerning the indications. You mentioned that you are using this technique, and it's usually used in the context of liver transplantation. Here, sometimes we are confronted with such cases with lesion, hepatocellular carcinoma, but it's absolutely contraindicated for liver transplantation because of segmental portal vein thrombosis. This absolute contraindication for liver transplantation. But a lot of results now from yttrium, we found complete ablation, normalization of alpha-fetoprotein, and after maybe 3 or 4 months, this patient, we can say that he is curative treatment by yttrium. In your experience, can you consider such patient for liver transplantation or not, considering malignant, proved malignant segmental portal vein thrombosis? This is the first part, but I need your comment. And you explained some of the explant pathology, but I didn't find any case with explant pathology post-resection or post-transplantation with history of segmental portal vein thrombosis. I need your comment or your experience, if you have any experience at this point.
Sure. So the standard treatment for for HCC patients or HCC lesions with portal vein thrombosis or invasion, the standard based on the BCLC guidelines again or algorithm is systemic therapy. As you can see in, I think they cut off the presentation, but that's fine. So it's usually systemic therapy. However, there is a new classification that is now done by the same Milan group. It's by Specifico. This is one of the group in Milan. These are the group that developed the Milan criteria, and they actually have a scoring system for those patients. It relies on the bilirubin level. It relies on the size of the tumor, whether it's more or less than 50% of the liver. And the third one is, where is the portal vein invasion? Is it main portal vein? No. Is it segmental or lobar? So, of course, those patients who are or who have a bilirubin of less than 1.2, and they have less than 50% involvement of the liver, and they have only segmental, not main or lobar, only segmental portal vein invasion, they have actually a median survival by Y90 only, without systemic therapy. They have a median survival of 32 months. So that's really outstanding. Again, by using a Y90 dose of more than 240 grays. So this is actually a study that has already, it's called Dosisphere study. So there's so you can always look at your patients. Is it, and it's like 3 scores, like three type of patients, 3 stages. Stage 1 is the best. It will give you 32. Stage 2 is you can do it, but you have to augment it with systemic therapy actually. It gives you a median overall survival of 14 months. Stage 3 is better not to do anything for them. They're gonna die anyways. And it's 6 months, so it's very comparable to just leaving them alone.
Yes, but I'm speaking about a special context with segmental. For me, I know that segmental portal vein thrombosis is absolute contraindication for transplant, yes. Bad prognostic for surgery. But if I have a patient with invasive tumor affecting left lobe with malignant portal vein thrombosis, and sure, we don't have any extrahepatic spread, I go for surgery. Whatever, and we have a lot of patients with very good long-term survival after surgery. That's why I'm asking, if you use yttrium in a patient with segmental portal vein thrombosis, and you are considering that he is curatively treated, your team and MDT, you can consider this patient in this context with small segmental portal vein malignant thrombus after curative treatment with yttrium, candidate for transplant or not?
That's actually, it's a downstaging technique, and yes, we do it all the time because, again, the survival is great, and we downstage them. and they go to transplant. That's why the median overall survival is pretty high.
Okay.
And there is actually a study that was done by the group in Northwestern about specifically those patients and how in certain patients, just exactly like you described, that's exactly what they described in the paper. Some of them, their AFP actually went back to normal.
Exactly.
Yeah, it goes back to normal in a specific type of patients. I don't have that on top of my head what exactly were the patients that had that, but mostly again was related to the dose. The higher the dose that you give, especially in these segmental, these are the good patients with portal vein invasion. So these need to get like high dose of Y90. You downstage them from being completely inoperable to completely being eligible for transplant because it wipes off everything and it disappears really. So, and they have really a great, even if you ended up not transplanting them, their median survival remains around 32 months, which is more than TACE or, it's kind of in between TACE and ablation.
Thank you so much.
As regard invasion of the main trunk of the portal vein, so it's a palliative. Can I understand that it's a palliative treatment with yttrium?
So it's if you do it for the main portal vein invasion, it's better not to do it at all because the median survival for these patients is going to be 6 months, which is very, very comparable to supportive measures, so I think, even for systemic, you'll probably be a little bit reluctant. Dr. Metwali can talk about this, but you're a little reluctant also to treat those, even though they still are eligible for systemic therapy. But again, the outcomes of these patients is not great. So they're very soon going to spread out in the peritoneum and in the lung. It's already probably spread by the time you see it. So you treat what's in the liver, but it's already spread. They're going to die from something else.
Actually, thank you, Dr. Ahmed, for your talk. I was just going to comment about that. Do you measure by any means circulating tumor cells before going into transplant after for the patients, treating them when they have portal vein invasion, the segmental portal vein, and you are going for transplant? Do you take care of the circulating tumor cells? Do you give any adjuvant systemic therapy? Up to my knowledge, there is no adjuvant systemic therapy after that, but the assessment of the circulating tumor cells, do you do that in your center before going into a major surgery and subjecting them to immunosuppression?
So let me just make sure I understand the question. You're saying that do we use systemic as a new adjuvant therapy before doing transplant? As a sort of...
I mean, these patients who have segmental portal vein thrombosis, and they have a very high risk of local and systemic recurrence by virtue of having a malignant thrombus. So, do you give them systemic therapy? That's the first question. Up to my knowledge, there is no adjuvant treatment till now approved. And the second question is, do you assess the circulating tumor cells just to find the risk, to assess the risk of recurrence before going into transplantation and a major surgery?
Yeah, that's a great question. We don't really assess the circulating tumor cells. That's something that we don't do, especially for segmental, the ones that we're going to treat. We really don't. I don't think it's, at least for us, is a standard of care. The second part of the question is, do we do, yes, and there's like 2 studies out right now showing that using Y90 for these, again, selective type of patients where the tumor burden is less than 50, bilirubin is less than 1.2, and it's only segmental portal vein invasion. For this group of patients, again, there's an already established 32-month median survival in 2 studies, almost like 2 studies. And these are studies that were well done, actually, by the same Milan group, So for that reason, I think we are more encouraged now to do that. And we are encouraged to use the high dose for these as well. And we have seen, unfortunately, I had one actually in the workshop, but we have seen like almost like complete response with these patients. So we always were able to downstage them. So, and they now become eligible for transplant, and they do that. And I think, like I said, it's you know, it's another way of treating these patients who have, like, number one, poor outcome, number two, not much options, except atezolizumab, which is the you know, the protocol that we use for the systemic therapy.
Thank you,
Thank you.
Professor Ahmed, for this very interesting talk. And we can move to the next speaker.